Okay, it's coming up. Okay, well, you're all set.
Very good. Hello, everybody. My name is Walter Glom. I'm the Executive Director of the Connecticut Council on Developmental Disabilities. And welcome to our fourth webinar in our series about access to healthcare for people with developmental disabilities. Over the past 2 months, we have heard perspectives on this problem from the national level, at the state level, and from marginalized communities within the state of Connecticut. Today, I'm really excited to have some speakers from 3 other states come and talk to us about some promising practices that they've developed there that we may consider to adopt in Connecticut to address this issue. Before I introduce our first speaker, I would like to introduce Dr. Tara Lutz from the University of Connecticut Center for Excellence in Developmental Disabilities, who has a few words. Tara?
Good afternoon, everyone. My name is Tara Lutz, and I am here representing, as Walt said, the UConn Center for Excellence in Developmental Disabilities. We are a very proud partner and collaborator on this project. I would like to, at this time, call attention to some logistics of this webinar. The Q&A button at the bottom of your screen is open for questions. Please utilize that space for any questions, and upvoting is active. We do have ASL interpreters for this presentation. There's a separate icon in the bottom of your Zoom screen. Click on the globe for that toolbar. And following the end of this session, we will be able to send out the recording, slides, and resources. And we do ask at the very end that you complete our short evaluation. Thank you.
Hey, thank you, Tara. I want to reiterate Tara's last comment there about filling out the evaluation, if you would, please. Tara and I are both federally funded, and we rely on your feedback to send in our reports back to Washington to keep the good work going. Now, having said that, I'd like to start with our first speaker. I'm pleased to have Dr. Megan Morris. She is the founder and director of the Disability Equity Collaborative at the University of Colorado School of Medicine. And without further ado, I'd like Dr. Morris to tell us about the good work they're doing. Thank you.
Great, thanks for having me.
Dr. Morris, you can just share your slides. There we go.
All right. There you go. Can you see that okay? Great. So today I'll be speaking on the topic of documenting disability status in the electronic health record. I have heard you have had a great introduction to the topic of disability health and healthcare disparities. So I'm just going to jump right in there and not give a whole lot of background on the disparities that exist in our country. So why are we talking about documentation? Documentation sometimes isn't necessarily the most fun topic. It doesn't necessarily seem the most innovative, but it's fundamental to the work we do. We can't improve what we don't measure. And we need to think about documentation of people with disabilities in 2 levels. First is the public health data needs. So we need to be monitoring at a population level the quality of health and healthcare of people with disabilities, monitor trends at the population level, and also make informed policy decisions. But we also need to think about documenting disability status at the healthcare system level. This allows us to track the quality of care delivered to people with disabilities at, again, the organization level. Organizations need to then be able to identify, again, gaps in quality so they can target interventions and then measure the effects of equity interventions targeted at these individuals. And then finally, and probably actually the most important, what we have heard from health systems is that health systems are legally mandated to provide disability accommodations according to the Americans with Disabilities Act, as well as Section 1557 of the ACA. and you can't provide accommodations if you don't know who has a disability. So I started writing and talking about this topic actually a little over 10 years ago. And we've done a series of studies to really build up the evidence on how to best document patients' disability status in the electronic health record for the purpose of, again, tracking quality of care at an organization level, and then identifying patients who require disability accommodations. So the first question we really tackled are, how do patients feel about this? We have heard over and over from health systems concerns that patients might be offended by us asking these questions. And I would say overwhelmingly, patients are very supportive of collection of their disability status in the EHR, as long as it's done in a patient-centered manner and in a respectful manner. We actually found that patients are more supportive of their disability status being in their EHR than actually other demographic characteristics. There's also a legal requirement. Like I mentioned, there's this legal requirement to provide accommodations. And so the DOJ has put out some recommendations on, again, how best to provide accommodations, and central to that is to make sure that health systems are consistently documenting patients' disability status and their accommodation needs. A few years ago, we did a series of interviews with a wide range of different stakeholders, from patient advocacy groups, from health systems to researchers to policymakers, state and federal level, et cetera. I could keep going on, insurance companies, et cetera. And we asked them, what are the priorities for advancing health equity for people with disability? And documentation of disability status in the EHR was identified as the top priority. We've also done work with health systems, and they repeatedly say that they are really struggling to implement consistent documentation. And there's multiple reasons for this. The top reason is that healthcare leadership might not see this as a priority. And they often don't see this as a priority for a few different reasons. One is they don't recognize or are knowledgeable about, again, the legal requirements about providing accommodations. Additionally, there's no guidance and standards out there for how best to do this. And so, so that can make health systems nervous. And there's concern about how much time this is going to take, and really, will it make a difference in their patients? So one advancement that we have had in addressing these concerns is a policy change. So as of last year, the Office for the National Coordinator for Health Information Technology, or ONC oversees all EHR sort of regulations in the country. And as of July of 2022, they actually released standards for all electronic health records to this was part of what's called their interoperability standards. So all EHRs have to have standardized disability data elements in them. Okay. And this is from their website. And then very, very bottom is a little red circle, and that's where a disability status now appears. So this is great, great advancement, and we've seen actually a lot of progress, specifically coming from EHR vendors who are working on adhering to these changes. So you can ask, so one of the questions we also get asked is, okay, what questions? And these are a set of questions and disability categories that is recommended. So I won't go into some of the politics about which question set that to be asked, but we have tested these questions. This is the patient-centered disability questionnaire. We have tested it actually in our health system here. We rolled it out in as part of new patient registration in 53 primary care clinics, and had over 3,000 patients go through with 0 complaints. With these questions, on average, it increased the length of, and this was for new registration, it increased the length of the call about 18 seconds. And we have a publication if you're interested. I'm happy to share this. But yes, so here are the categories. So hearing, vision, cognition, mobility, a fine motor, activities of daily living question, a communication question, and then we developed a general screener question. So, I am happy to say that, again, partially in response to the new ONC requirements, Epic, who is the largest EHR vendor in the country, we have been working directly with them. As of last November, all Epic users have these standardized disability categories available. What that means, though, is it's a little confusing, but it's the back end. So they have the buckets, we call, for the disability data elements. Health systems are still required to do 2 things. One, to develop the data collection tools to collect the data to populate the buckets. And then second, you have to actually develop systems and processes to ensure that there is consistent documentation. So in response to this, we at the Disability Equity Collaborative, and I'll take a second to explain what that is this is a group of stakeholders nationally who are interested and invested in healthcare equity for people with disabilities. We have a wide range of resources on our website for health systems on how to implement equitable care in their organization. We have 4 different work groups, one of which is our Documenting Disability Status work group. Again, Epic regularly attends those meetings along with a wide range of different stakeholders. We, together as a work group, produce this resource that is available on our website. This is Documenting Disability Status in Electronic Health Records, an implementation guide. This has resources for organizations of scripts of how to ask questions, FAQs for patients, training materials for the staff who will be collecting this information. We recently also received an NIH grant that we are in the midst of, where we'll be actually expanding this implementation guide and actually testing it in a trial. Also, a part of the NIH funded study, we are working with Epic to develop a standardized build for again, what I mentioned, the data collection tools, so that organizations can collect disability status through the patient portal or e-check-in or at different points of the care process. And that will be rolled out. It'll be available in the next year and then rolled out in the next few years to all Epic users in the country. So our other work groups, a part of the Disability Equity Collaborative, we have a standards and guidelines, a research, and another work group, which is called the Healthcare Leaders Work Group. And this is only for healthcare organizations. And it's an opportunity for organizations who are working on promoting accessibility in their organizations to get together, share ideas, and support each other in their efforts. And all of our work groups were always open for new attendees. So with that, I will say thank you and pass it on to the next speaker.
Thank you. Thank you, Dr. Morris. Now I would like to introduce Dr. Joven, who is the Senior Vice President at Cooper University Healthcare in New Jersey, to talk about the work they're doing there. Dr. Joven.
Good afternoon. My name is Francisca Joven. I'm Senior Vice President for Patient Access and Chief Experience Officer at Cooper University Healthcare in Camden, New Jersey. And I would like to walk you in the next couple of minutes through a program that started about 2.5 years ago And after concern that one of our parents raised about their experience through healthcare related to their intellectually disabled child. So the first thing that we did, we got together a group of leaders from Cooper, and we also formed a patient family advisory group that really guided all the work that I'm going to present to you. And about a year into our program, we were very fortunate to be the recipients of a state grant from the state of New Jersey. Fast forward to now, we built a program and are continuing to develop it that has 4 pillars. It focuses on education across the entire healthcare continuum, on facilities infrastructure. How can we build an environment that promotes the care of patients with intellectual disabilities, has an electronic medical record infrastructure that allows us to better coordinate care, and has a care coordination team. So talking about the educational pillar first, what we learned very quickly from our families was that the level of knowledge of healthcare providers, of nurses, technicians, medical students, residents, even attending physicians about patients with intellectual disabilities, and in particular nonverbal patients, varied significantly. So we partnered with our nursing leadership and developed educational materials for our nurses that are now embedded in our yearly nursing competencies and education, and that have been completed by all the Cooper nurses in this year's training period. We have educated anybody that crossed our path. We did numerous lectures to our medical students and residents. We held grand rounds with attendings in key specialties. We educated our entire senior leadership, admin council, vice presidents, and senior vice presidents, since they are the decision makers. We have multiple forums of education, such as lectures. We do lunch and learns. We have a team that does just-in-time education at the bedside. And we also partnered with other healthcare providers in the region and hosted one conference in April together with Bancroft, which is a residential facility. We are planning to have a region-wide nursing education session, actually 2 in November, where we focus our education heavily on nursing staff, office personnel. In addition to this, we are now in the process of developing mini videos that we can display on our social media during conferences, so that we use a variety of methods of education to increase knowledge about patients with intellectual disabilities. In addition to the educational pillar, the grant money allowed us to really improve the environment of care. And what we did is we developed a number of dedicated care spaces in a pediatrics office, in the radiology department, in the emergency room, that should be completed by the end of this year. And most importantly, we also focused on mobile devices that can improve the environment of care no matter where the patients are. These are mobile carts that are light machines and sound machines, have some tactile elements that we bring to the spaces where we treat our patients with intellectual disabilities. The feedback from our families, from our caregivers, has been spectacular, as it allows the patients to be more comfortable in the care environment. And it allows the doctors and the nurses to focus back the scope of the visit on the care, as opposed to relieving anxiety and agitation. We plan to deploy these devices to areas within the healthcare organization, both inpatient and outpatient, where we know that we have a large number of patients. We have also developed communication tools, social stories that we have distributed at points of care, so that we enhance the communication with nonverbal patients. We educate our staff about the existence of communication tools. And most importantly, we educate our healthcare staff that patients who are nonverbal can also communicate. What allowed this to happen was really the infrastructure that we built in the electronic medical records. With help of our healthcare providers, we created a list, and we know 7 days ahead of time what the point of contact for patients with intellectual disabilities will be across the organization. Office visits, laboratory studies, procedures, surgeries. And what this does is it allows our team to communicate with the families, identify what special accommodations they need, and also update our medical records with elements very specific to the respective patients. We also have really put a lot of effort in improving the accuracy of the medical record, as patients with disabilities cannot speak for themselves. Some are accompanied by caregivers who are not very knowledgeable about their medical information. And the importance of an accurate medical record cannot be stated enough. So our team really focused on looking at the problem lists, make sure that they're accurate and that they're updated on an ongoing basis. We learned from our patients the challenges of navigating healthcare, making follow-up appointments, completing the appointments that were made. So our team now calls patients after the visit and guides them through the appointment-making process. And through our special attention to the chart, we also know when patients miss visits and they need to be rescheduled. A little bit different than the initial presentation, we also developed a care coordination note focused on our patient population with intellectual disabilities. The note is highly visible in the chart and is completed as families and patients have contact with healthcare. But it allows our caregivers to have easy access to information like who is the guardian, who is the main caregiver, where does the patient live, and other specifics related to the patient. And lastly, we do have a care coordination team that is multidisciplinary. We have a clinical navigator that calls each patient before the visit. We have a patient relations representative that calls after the visit. And we hope that with this, the attention to care for our patient population will significantly increase. I would like to end by saying that we have a lot of feedback from our patients, from our families about this program, and that the reason why we believe that we were so successful in such a short period of time was that the level of engagement at leadership level was very high. 3 department chairs sit on our governance committee. I am one of the senior vice presidents of the organization. I update my senior vice presidents on a regular basis. And most importantly, this program was built with very frequent and ongoing advice from our patients and our families. And now when our group provides updates to the governance committee, the parents on the governance committee hold us accountable. So far, it's been a very successful program, and we are happy to connect with anybody interested to learn more about it. Thank you for your time.
Thank you, Dr. Jovin. We appreciate that. Please stand by for questions. I'd like to remind everybody that we do have a Q&A box available to you. So for those of you attending, please start thinking about your questions and dropping them in the Q&A. So we're prepared after our last speaker. Before I introduce our final speaker, I'd like to pause for just a moment to acknowledge the terrible loss that was suffered by our neighbors up in Maine last week. Dr. Pizzullo, who is the director of the Maine Primary Care Association, is unable to join us today because his organization is today meeting to deal with the aftermath of that tragedy. I am happy, though, to have one of my counterparts from Maine, Rachel Dwyer, who's the Associate Director of the Maine Developmental Disabilities Council here, to tell us about the work that's going on in Maine. So, Rachel? Rachel, you're on mute.
Of course I am. You have to do that once. Thanks very much, Walter. This is like, I wasn't expecting you to say that, so I was just pulling myself together here. Great. I appreciate your inviting me to be here today. And I'm happy actually to share this work and hope to fill Chris Pizzullo's shoes fairly well. I'd like to tell you about some work that the Developmental Disability Council did with Maine Primary Care Association, which is a membership organization representing the 25 community health centers in Maine, who provide basically all access to care for about 1 in 6 people who live here, including just about 100% of people who live away from the population centers. So it's a critical it's a critical place for people to be accessing care. And the Maine Primary Care is become a patient safety organization, and so we are so we've had the opportunity to work with them. We have actually, yeah, okay. Aha, thank you. So the DD Council has worked with Maine Primary Care Association for well over a decade. And I really bring that up just because of to make some of these on the ground trainings. I think that the length of time for building relationships and the ability of working with the council, which enabled us to do an early project back in the 2010s. It was okay. It was not amazingly successful. It was pretty traditional education-based intervention for what we saw as gaps in primary care for patients with intellectual and developmental disabilities. However, that relationship or that project gave us we kept in contact and continued to think about how to address this, and were able to execute a pretty substantial amount of work around increasing patient safety and looking at practices, the readiness of practices to address the needs of people with IDD. We really have, it sounds like everybody has really covered the background of the problem really well. I think what we really, the way that we looked at this was through a lens of patient safety. And we worked with we worked to acquire a database of patient safety events or adverse events among patients in Maine who had medical related indicators of having developmental disabilities, and to analyze them really so that we could take some of the what people know and say, well, what does that really mean? What's happening on the ground? And really so that the practices could look at it in terms of their safe tables, in terms of how do we reduce medication errors, how do we reduce incidents like that impact individuals' ability to impact care, sometimes behaviorally, sometimes sometimes because of communication barriers, and ultimately to create a surveillance and intervention tools for primary care interaction. So again, we started with the database of patient safety events, and it was a pretty small data set, and it led to the question of, so what's happening? Can we get a bigger set? What would we see? What would happen if we looked at a bigger set of data? And ended up partnering with ECRI to take a look at the national data set and to parse that out, to say, it's parse that out, so we would end up with some work that was applicable, that had broader applicability than to 25 care practices in a small rural state. So the process was pretty straightforward. I think from there, was taking a look at the local data, taking a look at the national data, taking the pulse of the physicians providing the care, taking a look at the published data, some of which has been referenced in other, and then to host the provider safe tables, in which some of the issues directly related to providing care to those individuals with IDD. And also the inclusion of parents or family members of people with lived experience was really critical piece to it. The safe tables were really amazing. That was an offline kind of an offline private discussion. It was an opportunity for care providers to really put out there some of the things that they really saw as difficulties in providing high quality care to individuals with developmental disabilities. And really, like, the topic of stigma came up, the topic of feeling unprepared to treat these patients. But a really beautiful outcome here was having a provider make a transition, really, from saying, well, I don't know how to treat people with IDD, to really saying, oh, these are really our patients, and they're our patients, and we have to, it's not there's nobody to send them to. This is who needs to be, this is who needs this kind of high quality care. So we developed a patient safety brief from to provide evidence-based recommendations around patient safety concerns, and a readiness tool for the treatment of people with IDD. And some of them are just listed here. They're pretty, some of them are pretty low technology, pretty low technology interventions that were accessible to providers in tiny clinics with limited resources. And consider the staff preparation as being more than the physician or the primary care provider. We looked at the office staff and the auxiliary staff and and I love the fact that the medical records stuff is here, because that was really also really identified. People with lived experience talked about issues that, again, we've heard the previous speaker talk about social stories, asking people what they need, asking people what a safe visit or what would be like, having paperwork be completed in advance, minimizing safety or sensory overload. I'm sorry, like when do you schedule people? Not all of these things were possible for every practice at every time. And so many of them were when people were able to have, the patient is flagged as somebody who needs to have this consideration, and by and large, that the success rate increased. The ambulatory care readiness form was distributed to the practices, and a number of them have utilized it. This is available. This is the tool right here. It's very short, and kind of lays it out there about what are the considerations for scheduling, for offices, for care provision, for staff preparation, it's been introduced and used effectively. This is my colleague Chris, who is not available to be here today, and he talks some more about the impact of this in his work right here at this link. And I'd like to just close by I would not have thought, we've been 4 years ago, that a partnership with a patient safety organization was going to directly lead to an improved primary care experience for people with intellectual and developmental disabilities, and we really the openness to the lived experience of people with IDD and their families, as well as the professional expertise of the folks who are coming to the table, and willingness to learn and really desire to improve the care have been so important. Feel free to contact either one of us. Chris is probably the best person to contact with clinical questions. Thank you.
Oh, there we go. Thank you, Rachel.
Right.
That was terrific. I really appreciate all three of you sharing all that. I think we have some questions in the Q&A, so I'll hand it back to Ellen to begin with the
Yeah,
questions.
we do. We have, I'm going to take the second one first because I think it's faster. Can you please, this is from Karen Buckley from the Hospital Association. Can you please share the form with participants of this webinar? Rachel, if you could send that to me and to Walt, we'll make sure that it gets out to everybody.
Right.
So that's answered. Andrew Bate had a question. Dr. Joven, have your efforts been focused specifically on pediatrics and children with intellectual disabilities? If so, given the success of your efforts, are you considering expanding your efforts to adults with other developmental disabilities?
So thank you for your question. Actually, our program started with adults because we realized that in the pediatric space, the providers, the healthcare providers, the doctors knew more about the diagnosis and the management of patients with intellectual disabilities. And yes, we are planning, once this program is more matured, to also look at other cognitive impairments, and that patients who share a lot of the commonalities with our patients with intellectual disabilities, such as not being able to make healthcare decisions for themselves, and most importantly, not be able to be a voice for themselves.
Great, thank you. We have a question from Sheldon Todman, who's from Disability Rights Connecticut. In Maine, are the health centers experimenting with the kinds of value-based payment which puts financial risk directly on providers, such as capitation? And if so, is anyone trying to measure the impact of this on access to care for people with disabilities? I ask because these models, which are being pushed by some in Connecticut, incentivize providers to restrict access to care for their own patients, since there is little or no payment for each visit. This is a problem for all patients, but particularly for people with disabilities who tend to have greater healthcare needs and may require more time per patient visit. And so may be particularly problematic for a provider who is receiving no compensation for office visits. Thank you for any information about this. I think that could go to all of our speakers.
Well, yes, there's talk of that in Maine. Maine has a fairly low, Maine does very little in the way of Medicaid managed care, and value-based purchasing has been talked about for a long time, but it became fairly heavily politicized. So the kind of the rolling that out has been difficult. Those problems absolutely have been identified. And in terms of people with IDD, how that began being addressed was to really carve people out of those programs to leave people in a fee-for-service model. And the same thing, of course, happens with other folks with disabilities, and that has been addressed to some extent by creating what they call behavioral health homes, which I think provides like a little bit of a broader access to certain types of care, that isn't quite as problematic for providers. But for sure, yeah, that's that's a difficulty. And we certainly identified that having people in their own system is also of concern, because it's a very, very small population. So relative to the other folks in the Medicaid system. But yeah, thanks.
So what I would like to add to that is that in our program, we have a clinical navigator that prepares the patients for the visits. We ask about medication. We try to start the steps of medication reconciliation, which are time consuming. And we have in many instances this pre-conversation with the caregivers or family. And what that has allowed, it has allowed the physicians to really concentrate on the medical questions and medical examinations during the visit. So through our wraparound services, we tried to allow physicians to spend more time with the patients. Also, through our very tight follow-up that we're putting in place, appointments don't get missed. And then, or if they get missed, they get rescheduled. So we hope that with time, we should be able to show better outcomes. And with better outcomes, also less healthcare spending.
Yeah, and I'll just add that, yes, people with disabilities may take longer during clinical encounters, but I think there is the assumption that they always do. And I think some of that is based in some ableist beliefs and practices. And so there's been, a series of studies that have come out in the last few years about providers' biases and stating facts that they are not welcoming to patients with disabilities in their practice. And, the title of one talk by Tara Lagu was, "I'm not the doctor for you." And so we need to look, though, how can we as a healthcare system actually do better and actually improve the care to make, if we're providing better care, ultimately the patients will be less sick. And so they're going to need to come in less, they're going to have less chronic conditions, etc. But then also, again, how do we design the healthcare setting to make sure we're being accommodating? So I've had providers talk to me like, yes, when someone comes in a wheelchair, it's such a pain, it's so problematic that they're in the wheelchair. And then you press them and they say, oh yeah, well, we're doing construction in our parking lot and we didn't have a way for them to, efficiently get into our building. And then we scheduled them in the wrong room without a height adjustable exam table. And so they sat out in the hallway, for 10 minutes while I was, moving patients around and all of those things. Yes, that took longer for that clinical encounter, but had really nothing to do with caring for that patient's disability. It was, again, looking at the environment. How do we make this more accommodating, which is going to ultimately be more efficient?
Ellen, I have a question for Dr. Joven, if I may.
You may, because we don't have any, so I would urge people to put questions in the Q&A.
Doctor, I'm impressed with the quality, the extensive wraparound system you seem to have. We had some experience here a few years ago as a council providing COVID-19 vaccines for folks, and we learned a lot of these lessons about the need for extensive pre-consults with families, before the appointment, right? To understand the accommodations and all of that. What I'm wondering in your case, it sounds so impressive. How are you paying for that? Are you doing that in a fee-for-service environment, or do you have some alternative payment method? And how do you make that all fit, all of these teams and wraparound and care coordination?
So, as I mentioned earlier, we received a grant, but as we developed the grant, we used the grant money to implement processes and to define the work and the workflows. We are not caring for new patients. We're caring for the same patients that we were caring for before. We're just doing it now in a more efficient and organized manner. So while we started out initially with support to our team from the grant, what we're planning to do is embed that work into the organization and look at how can we have one provider with expertise that touches as many patients as possible with IDD without necessarily adding a lot more manpower, but using the manpower differently as an organization. So our clinical navigator contacts patients regardless where they hit healthcare. So she helps the folks in the offices or in the operating room. And if you think about the number of full-time people that we added to the grant, we are somewhere about 1.8, but we have carved out the work that they need to do with laser focus, so that while we are very mindful of our dollars, we also achieve a lot at the patient level. And Cooper cares for, we have now in our registry about 400 patients with intellectual disabilities that touch our system. For about half of them, we're primary care providers. For half of them, we are specialty providers.
Oh, well,
Thank you for that.
Interpreter switch.
Okay. I had a question, Walt,
Please.
and maybe to all of you. You talked about navigators, Dr. Joven. Do you use community health workers, and how do you use them, and how have they been trained to accommodate patients with developmental disabilities?
So at this point, we do not. We partner, however, with Bancroft, which is a residential facility with whom we share about 100 patients for primary care, and are just in the process of establishing a relationship and see if we can move more of the care into the home so that we prevent the hospital or the office visit in the first place if we can, but we have not been using community health workers.
Okay. Dr. Morris or Rachel?
Yeah, I want to point out that, and I feel like it's not really well known, but the ADA and Section 1557 of the Affordable Care Act requires all healthcare organizations to have someone oversee all accessibility initiatives at their organizations. And what we have seen is a wide variety of how organizations are making this work. So some organizations are saying someone in their compliance officer or office of, hey, you now have the title of ADA coordinator, create some policies for us. Other organizations are hiring people in this role specifically as an ADA coordinator, and they actually have all types of names, and they are boots on the ground working on implementing accommodations. I'll say there are several organizations like Mass General in Boston and Boston Medical Center. They've expanded their office for their ADA coordinator role to include what they're calling they have specifically focused on autism, those programs in autism, like care coordinator. So again, every organization, and it's actually every place with 15 or more employees has to designate one person to be in charge of this. And so I think it's a underutilized role, and it is something we should be thinking about. Again, how do we equip these individuals to care for people with, provide accommodations and these care plans across, different types of disabilities.
Great. Rachel, I don't know if you wanted to answer.
Yes, except I'm just going to say, no, that isn't something that's been used here. The community health workers here are primarily have been used for immigrant health access. And I've not ever heard of it being talked of more broadly, although it's an interesting idea.
Great. We do have a question from Ruth Grobe. One of our disability advocates is interested in the idea of assigning doulas to patients with developmental disabilities. Has this approach ever been considered?
I actually just heard about that this week as well. There was a piece published in the New England Journal of Medicine, and where it mentioned doulas. I don't know of any place that is implementing that, but it is something that is being talked about at the moment.
I think it's definitely worth exploring. We currently very often assign a sitter if there's no family member present. So certainly it's something to be explored.
I agree. I think that it's an interesting kind of way of framing it up. Certainly the folks with IDD who get into the hospital system have that experience. And if there's an inadequate number of, if there's staff or family who are unavailable, it certainly would be helpful if the person who is supporting them had some expertise in providing care, since so often it's somebody who's extremely unhappy, about it's just a really traumatic experience that somebody's engaged in, so.
Thank you. I'd have one more question before we wrap up, and this is mainly to Dr. Joven and Rachel. Dr. Morris talked about the development of electronic health record standards that would capture information about disability that could be used for scheduling and accommodations. Are you using any such system now? And how do you see that kind of data helping or not the systems that you're developing? I'll start with Dr. Joven.
So our focus really has been on identifying patients when they hit the doors. I certainly walked away with a lot of ideas from Dr. Morris's presentation. What we have focused on with the electronic medical record is we have a daily email that is distributed to a number of people who are managing hospital throughput, office throughput, with all the patients, as I said, that will come and hit the health system in the next 7 days, and with all the patients who had an encounter that was unpredictable. We also do have a flag in the chart that tells us that that the patient we're looking at is a patient with IDD, but we do not have yet an alert that flags for the folks who are scheduling. So I walked away with the idea from this meeting. Thank you. That is maybe the next step where we have to go.
Rachel?
I think that the question of electronic medical records, I think, I could talk for a week about the challenges in a state that has a couple of big healthcare providers and a lot of small ones. I think the largest one does have some ability to identify what kind of accommodations people need. But by and large, I think that people's medical stuff doesn't even follow them from one, necessarily from one place in the community to the next. Never mind information about disability. They're sometimes their report, their results from their blood work, so that's I think an ongoing continued challenge here. So, and it would be great to have that fixed.
Thank you, Rachel. Are there any other questions from our attendees?
I don't see any, Walt.
Okay, well, thank you all on the panel. This has been valuable to us, and you may be hearing more from us as we develop our solutions here in Connecticut. To all of you who have been attending, I want to encourage you to complete the evaluation. You can see the QR code on the screen there. Please, please, please make our federal reporting easier by providing us with data to report. Our next scheduled session in this cadence was going to be on Tuesday, November 14th. I have to announce today that that's not going to be possible. We're trying to gather a group of physicians here in Connecticut who are doing some promising things, and unfortunately, their schedules do not allow them to speak on the 14th. So we will be scheduling a session with a number of folks who are doing some promising things at both in private practice and in a couple of the large teaching hospitals here in Connecticut. And you just have to stay tuned, and we'll let you know when that date is going to be. Otherwise, I want to thank everybody for being here today, and I look forward to seeing everyone the next time we gather.
Thank you.